Just so you know, we are recording this meeting, so it is available for those that can't be here live. And we'll go ahead and bring up the slides that we have here. So welcome to the JVS Online Journal Club. We're excited to have everybody here this month. We have two articles that are in the contemporaneous JVS that we're going to be going over, which are the primary mechanism of stroke reduction in transcarotid artery revascularization is dynamic flow reversal. The authors from two of the institutions on this multi-institutional paper from USC and also from UCSD will be joining us. And then we also have our second article, which is comparison of surgical versus percutaneously created arteriovenous hemodialysis fistula, and we have authors from from two different institutions joining us as well. Our host institutions this evening are the University of Rochester. Dr. Michael Stoner will be joining us as the faculty, and Dr. Eli Robbins is his fifth-year integrated resident that will also be presenting the article. From St. Louis University, Dr. Matthew Smeds and Dr. Charles Marquardt will be presenting as well. We're lucky to be joined by the authors. As I mentioned, we have Dr. William Jennings from the University of Oklahoma and Dr. Alexandros Malius from France joining us. And then from UCSD and USC, Dr. Mahmoud Malis, Dr. Isaac Nazi, and Dr. Greg McGee. We've also are very fortunate to have two special guests who will be our moderators for each article, Dr. Jens Jorgensen and Dr. David L. Dawson, who is the chief at Temple VA. Just a few little housekeeping tips. As always, we do ask that you stay muted. You can put your questions in the chat, and the moderators, as they go through the articles, may ask you to unmute to go over some of your questions to clarify. The event is being recorded for on-demand access for those that can't be here. And then we'd love for you to join us for the August version. It will be August 10th at 8 p.m. Eastern. It's being hosted by Dr. Vic Kashyap at Case Western University and also Dr. Sadiq from the University of Texas at Houston. So without further ado, I will stop sharing my screen and we will go from there. Dr. Stoner, do you want to start?
Yep, very good. 1 second, we're sharing screen. All right, you guys got it?
Perfect.
Thank you. All right, well, Misty, thank you for the kind introduction. Misty and Paul, thank you for organizing this meeting, and thank you for the attendees tonight. I look forward to the discussion of this paper, and it gives me great pleasure to talk about carotid endarterectomy, and it's been obviously that's the cornerstone of why many of us on this call even went into vascular surgery in the first place, an elegant operation, but it's evolved now, carotid endarterectomy, into a variety of therapeutic choices, and the new kid on the block, as it were, is TCAR, transcarotid artery revascularization, and we've been proponents of that as well. You can see the small picture I have in the top left corner of the slide of E. Scott Pickering and Rob at that operation at St. Mary's Hospital in 1954, wherein surgeons took control of stroke risk reduction. It's probably one of the most important operations that took place in modern surgical history, and certainly it's why I became, as I alluded to, a vascular surgeon. And the few slides I had just about the introduction, I think it's interesting to look at vascular surgery and the endovascular revolution, which all of us on this call, the faculty, have lived through, and the trainees are well into the revolution. And the example here from the chart on the right-hand side of the slide is from a Mike Jaff paper, just showing the, actually, no, I think it's not Jaff, but it's an increase in endovascular interventions over time, the decrease of amputations. The important part is just to show the asymptotic rise of that curve of endovascular therapy, pioneered by Charles Dodder, and in the aortic world by Roy Greenberg, you can see here. But in terms of the carotid, it's sort of been crossing the Rubicon when you look at carotid revascularization. And there's a variety of failure modes as to why carotid revascularization from an endoluminal technique is really not taken off. And I thought it would early on, and I was an early supporter of transfemoral CAS in my young days as a faculty member. But crossing the lesion in unprotected fashion, and then the various locations of atheroma disease from the femoral artery all the way up, and having just unstable anatomies for delivering the products. And what happens is that that translates to stroke rate. And the CREST trial shows us a CAS stroke rate of 4.1% compared to the gold standard of CEA at 2.3%. So the failure mode, really the idea of the distal protection filter, which is the mode for largely for most carotid stents, if you get rid of things like a MoMA device and talk about how the most stents are deployed, distal protection with a filter, which is borrowed technology from coronary vein graft intervention, really is not an ideal system. You cross the lesion in unprotected fashion and debris can escape around the filter, which is shown in these white lesion pits on the MRI on the right. So TCAR came along, and the idea of transcarotid artery revascularization, which began as case studies and then a commercially available device after Roadster trials, sets up a very robust flow reversal circuit, a flow volume that can approach up to 700 cc's a minute in a benchtop setting. So a very robust flow reversal system. Essentially, what operators often learn with this is that if you can get the system in safely, you can perform high-risk carotid interventions with it, and you can get the system in exceedingly safely. And that's borne out in these MRI trials that have looked at DW MRI hits. So if you look at the top there, ICSS trial for CEA had a 17% hit rate for new ipsilateral DWI lesions. Proof trial, which was a small study that looked at 56 patients undergoing TCAR, had an 18% hit rate. And then compare that to the transfemoral carotid stents to see at the bottom on the right. So a technology that has shown a very low stroke rate and very low occult stroke rate. And with that, I'll turn the discussion of tonight's paper over to Dr. Robbins, one of our fifth-year residents.
Like Dr. Stoner said, thank you for having us, and thank you for the SVS for hosting. I think this is just an absolutely wonderful event and something that we've been following for the last several months. And it's really a privilege to present on this stage. The paper I'll be presenting is out of UCSD and USC, titled Primary Mechanism of Stroke Reduction in Transcarotid Artery Revascularization is Dynamic Flow Reversal. As Dr. Stoner alluded to, optimal management of carotid artery stenosis has been a debated topic for the last several decades. And initially the battle for supremacy was between carotid endarterectomy and carotid artery stenting. However, in 2012, the new technique, transcarotid artery stenting using the in-route distal embolic protection device, was unveiled. And it became commercially available and FDA approved in 2015. At that time, the Roadster trial demonstrated an impressive 1.4% all-stroke rate, which was significantly lower than anything demonstrated with CEA and CAS. Early outcomes of Roadster 2 were similar, demonstrating an even lower 0.6 stroke rate in the per protocol population. So the question tackled by UCSD and USC became, where in the procedure is risk mitigated, and when does this happen compared to carotid artery stenting? The objective, specifically head-to-head, is there clinical benefit from flow reversal compared to distal embolic protection? And second, does arch navigation play a role in the historically higher stroke rates seen with distal embolic protection device? This was accomplished via retrospective review of prospectively collected VQI data, querying both the CAS and TCAR data sets. Of note, the TCAR data set is the newer of the two and was established in 2016 through the TCAR Surveillance Project. And this project has been great for us, not only as an institution, but as vascular surgeons in general, as it granted reimbursements to VQI participating centers treating high-risk asymptomatic patients. Of note, there are over 250 variables in this data set, making it very robust. All-cause mortality was determined through linkage with Social Security. The inclusion criteria were patients undergoing CAS from September of 2016 through November of 2019. However, only those with atherosclerotic disease or restenosis were included. Demographics were compared using univariate analysis, which we'll see on the next slide. Primary endpoints were composite in-hospital stroke or death, with secondary endpoints being stroke, death, TIA, MI, all as individual endpoints. Stroke was defined as neurological deficit lasting greater than 24 hours and TIA less than 24 hours. MI was defined by elevated troponins with symptoms of angina. For analysis, groups were propensity matched with multivariable logistic regression. There were over 21,000 procedures queried. Of those, over 9,300 transcarotid stents were done. 8,400 or 8,426 met inclusion-exclusion criteria. And again, all of these were performed through the transcarotid approach. 247 or 3.4% were performed with distal embolic protection. And the reasoning for using this versus flow reversal was not identifiable in the paper. The other 8,139 cases used the in-route flow reversal. Secondary analysis focused on the role of arch manipulation by comparing patients who had undergone transfemoral carotid artery stenting with the 287 patients who had undergone transcarotid artery stenting with distal embolic protection. As mentioned earlier, multivariable logistic regression and propensity score matching were used to explore differences in outcomes between transcarotid stenting with distal embolic protection and TCAR. Table 1 illustrates the variables examined before and after propensity score matching. An absolute standardized difference of 0.1 indicates that covariates were imbalanced between groups. Imbalanced variables prior to matching can be seen in blue and include age, symptomatic status, stroke, hypertension, previous smoking history, current smoking history, CHF, ipsilateral CEA or CAS, aspirin Plavix administration, and general anesthesia. There were over 274 match pairs examined as seen on the right-hand side of this table, and propensity score matching improved balance in all variables discussed above. Table 2 demonstrates in-hospital and 30-day primary and secondary outcomes in both matched and unmatched data sets. In the unmatched table seen on the left, TCAR was associated with lower risk in all composite endpoints that included stroke, as seen in blue. This also included stroke death at 30 days. Interestingly, death at 30 days, which was the only one that did not include stroke. The unmatched data set also demonstrated significant differences between the individual endpoint of stroke and death, like I mentioned here in the table. When individual endpoints were examined, both death and MI were not significant, and matched analysis demonstrated similar data. However, composite endpoints, including MI, were not significant, nor was death at 30 days. In both matched and unmatched sets, significance of composite endpoints really appears to be driven here by stroke alone, as seen in red. Table 3 demonstrates the secondary analysis, which compared patients who had undergone transfemoral carotid artery stenting with distal embolic protection with the 287 patients who had undergone transcarotid artery stenting with distal embolic protection. The unmatched and matched outcomes can be seen above. In the unmatched analysis, transfemoral carotid artery stenting had a lower rate of perioperative stroke death, 30-day, that seemed to be driven by a lower rate of in-hospital stroke. However, after propensity match or score matching of the 268 pairs evaluated, the differences were no longer significant, as seen on the right-hand side of this table. So in conclusion, the authors noted that transcarotid artery revascularization was associated with a lower risk of stroke and stroke or death. And this was compared to transcarotid artery stenting with distal embolic protection in 274 propensity matched pairs of patients. Death, MI, and composite of stroke, death, and myocardial infarction risk did not differ by neuroprotection type. With that, I'd like to say I thoroughly enjoyed reading this paper, and it was a privilege to present. I'm always envious of these ideas because, I mean, we do a lot of TCAR here, and This idea was right in front of our face. I commend the University of San Diego and USC for their work, and I really appreciate them being here to discuss this. There were some areas warranting discussion in the paper, and I appreciate the authors recognizing some of these, like the power with the limited number of transcarotid artery stenting with distal embolic protection in the article. The main one I'd like to recognize is the reason for transcarotid distal embolic protection approach at all. I assume this was either from failed TCAR or arch anatomy, but as we all know, when it comes to these data sets, that is always in question. I think the reason as to why this treatment method was chosen is really pivotal in understanding the data. And so I was hoping that the authors could really just start this off by elaborating on this for us.
All right, thank you very much. I'd like to commend the folks from University of Rochester for that nice presentation. And Dr. Nazir, Dr. McGee, do you want to respond to that initial question?
Dr. Nazir, do you want to take that or do you want me to take that?
Okay, I can start and then you can pitch in. Thank you for the question. So it's a limitation of the data set. We couldn't really tell what were the reasons why some patients undergoing transcarotid stenting were done under distal embolic protection. And so we admitted it as a limitation in the manuscript.
Okay.
Yeah, so basically I would just completely agree with the question, which is, you know, this is a retrospective data set. It's all the caveats of retrospectively collected data apply. And we agree that that is really a fundamental question. Why did someone choose distal embolic protection versus dynamic flow reversal for their method of stroke prevention? We don't know that. It's impossible to know from the data set. We came up with this question because really VQI provides a natural experiment to analyze, and that some people are doing this. We're not really sure why, but if you evaluate the outcomes of patients who are similarly matched, you can sort of determine if there are major differences there, and that was the nidus for the idea.
Can I just add a little bit to this? Mahmoud Malas here. So thanks, Dr. McGee, for filling in a little bit for me here. But first, the presentation was really very nice and brief and beautiful, and I like the historical part that was presented first. So thank you for doing this, and the nice comment. Ellie did a really great job presenting. Isaac is really did a phenomenal job here with this analysis. He's my postdoc fellow, and he get all the credits. The question always in my mind is like, you know, specifically why would that happen? And I think, you know, although we cannot prove it 100%, but way before Silk Road and way before there was TCAR, when I used to do all the transfemoral stenting at Hopkins, you know, learned really early on, more than 15 years ago, that, you know, you can do it on elderly, you can do it in bad arches. And we did a lot of research that led to that, you know, not operating on octogenarian. But, you know, as we learn with time is that it's the arch. And then I started just cutting down on the carotid in difficult arches where I couldn't get into, you know, type 3 arches, or I got in and my sheath popped out. So, and this is when I start just doing transcarotid stenting with the filter, because I still believe the filter, there was so much data that shows, you know, 50% almost reduction with stroke. And then based on that research, Medicare now does not reimburse you if you do transfemoral stenting without distal embolic protection. So it has to be the 37215 code for the CPT code. So if I can just imagine what happened here, I would say most people who have done transcarotid artery stenting with distal embolic protection, probably very experienced vascular surgeon, carotid stenters that couldn't do it transfemorally and then went transcarotid. And obviously the obvious problem with that is that they might have done already an arch angiogram and shower and cause a stroke before they cut down on the carotid, potentially. But I can see that this is probably the more likely reason. Why didn't they do TCAR? Maybe at that time they did not have access to TCAR, or they were not, you know, certified to do TCAR yet. That's the only logical explanation I could think. of why you would just do distal embolic protection through a transcarotid and not use this system that is approved by the FDA.
Thanks very much, Mahmoud, for your comments. Mike, I really appreciated your historical vignette about Charles Robb. He was actually the chair of the Department of Surgery when I was a medical student at Rochester, and he was quite a figure, a giant. As surgeons and researchers, it's important for us to know what works, but it's also important for us to know why it works. And Dr. Nazi, McGee, and Malas are to be commended for this very clever and elegant study that has sorted out why TCAR works. We all have talked about, manipulating the wire across the arch, going up into the common carotid. But what they have shown is that really the crux of the success of this procedure is due to the flow reversal. So one of the questions that's in the chat box, I think it's coming from Dr. DiMuzio, is would any of you care to comment on why the previous flow reversal devices did not work, the MoMA? Why didn't they work and TCAR is so successful?
Isaac, do you want to take that or you want me to?
I think I would defer to you, Dr. Malas.
So, the MoMA, I think it's a great device. And, before the MoMA, there was also the Gore system with flow reversal, transfemoral. That was very cumbersome, and it was 9 French that you had to put that sheath into the arch and then into the carotid. And then you had to select the external carotid and put a balloon in the external carotid to stop the backflow from the external. A lot of manipulation in the arch, large system, very bulky, not smooth. And then also a lot of manipulation around the lesion before you can establish the flow reversal. The MoMA I think it's a lot smaller and easier to deliver and does not require external carotid artery selection. So to answer the question specifically, again, the MoMA and with the flow reversal, you're still adding, the arch manipulation. So this paper by any means does not say that, avoiding the arch is not important. It's just within the data limit that we have and the small sample size and the matching that we did, we showed that the flow reversal would probably play a major role. But it doesn't mean that, going through a very atherosclerotic arch type 3, that's safe by any means. We don't want people to conclude that it's okay to go transfemoral, especially in people with bad arches. I think, the flow reversal piece as well with the TCAR is the fact that you're clamping the carotid. And you can't do that with the MoMA device. With the Freedom trial that we did with Gore, you will inflate the balloon around the sheath and that simulates, the clamping of the carotid. And same with the MoMA. But, with TCAR, I think, you're also clamping the carotid artery and essentially preventing any flow distally. And I would say probably people who did the transcarotid with distal embolic protection, probably there is no clamping of the carotid, so you can have a flow in the filter, thought to be protective. So I think clamping the carotid is a big component here.
Okay. One of the limitations in the paper was the small sample size. It was really only a couple of hundred patients. Do you feel confident, and this is to any of the authors, in your results? Does the power analysis show that you can be fairly comfortable in what you're showing here?
That's definitely Isaac.
Yes, the sample size was definitely a limitation, but we are definitely comfortable with some of the primary outcome that we reported. It is unlikely that the principal finding that lower stroke with flow reversal will change even with a larger sample size. So we are very confident. The only difference with regards to the secondary analysis is that maybe with a larger sample size, we might actually find that crossing the arch may contribute some benefit to the reduction of stroke.
As Eli pointed out in the presentation, this was FDA approved back in 2015, but CMS did not approve reimbursement unless it's entered into the VQI registry as part of the Transcarotid Surveillance Project. So you must participate in the VQI and enter the cases into the registry. And with that, we are going to, the TSP is going to be looking at the performance of TCAR to the standard of care carotid endarterectomy, looking at 30-day and 1-year outcomes, stroke and death. And that TSP project is still ongoing, so it still requires participation in the registry. In the chat, Lori Drudy from Canada points out that it's not available in Canada and wonders if anyone has looked at the sort of financial implications of TCAR versus carotid endarterectomy.
I know that there are a couple of studies ongoing, and Vic have worked on this, but we just recently published in JVS a cost-effective analysis comparing TCAR to CEA. So although obviously CEA is a lot cheaper because you're not adding, the cost of the system with the flow reversal and the stent, the cost effectiveness based on quality improvement it was more with TCAR, but this is probably the first paper that looked at the cost-effective analysis between the two, and by far is not going to be the end of all, but just a modest contribution to the literature.
One more quick question: TCAR is comparable to carotid endarterectomy. How do you decide, to Dr. McGee and Dr. Malas, who gets a TCAR, who gets a carotid endarterectomy?
I'll let Dr. McGee answer that.
Funny. So yeah, that's a really good question. I think, well, TCAR is going to be getting soon, I believe, approval for low-risk patients, but currently low-risk patients are not approved for TCAR. So those would be patients who would get carotid endarterectomy for sure. And then I think that if patients have, all of the anatomical issues that we often talk about with carotid stenting, high lesions, reoperative neck, radiated neck, et cetera, those are the ones I would certainly favor TCAR. Mahmoud?
Yeah, no, I totally agree. So right now, if you do a TCAR on someone who does not meet at least one of the anatomic or medical high risk, even if you enter it in VQI within TSP, you do not meet the criteria. For today, for TCAR to be reimbursable by CMS and all private insurance to typically follow, you have to have high-grade stenosis greater than 70, and then you have to meet at least one of these anatomical and medical criteria, and you have to have VQI and enter the TCAR. And so if the patient is symptomatic, you can get reimbursed without being in TSP. Not that we recommend that, but we want everything to be entered in VQI. But if you're asymptomatic and you do TCAR, not only your professional fee, but the entire institutional fee will not be reimbursed by CMS. So you have to have the VQI and put that specific code within the form. So it triggered that this is for CMS, that this is part of the TSP, like Jens was talking about. And just one thing about making a point for, there are a lot of residents and fellow, this is like a very stimulating for people to think about what you can do with VQI. You can have, access to the national data, and you have thousands of patients. Even though we end up with 270 match pair, that's a huge sample for this particular question. Now there's more than 22,000 TCAR. There's so much you can do with this. And the other important thing to show that how VQI can collaborate. So Dr. McGee is 200 miles away from me, but we did this project together, and he had a great addition to it. And so I just want to stress, kind of for the residents and for the fellows to kind of consider using VQI and entering the data in VQI.
I'd like to thank all of the authors and all the discussants. Really great job. And I will turn it over to Misty and Paul.
Yeah, and one minor thing at the end. I just want Isaac to get the credit. And I know a lot of, high rollers here and program directors in here. So when you guys looking for your next 05, Isaac is applying this year, and he will be a huge addition to any program. So just thank you.
Come on over, Isaac. Come on over, man.
Thank you.
Well, very nice. Thank you all for kicking us off with the first article. We'll now be moving to our second article, which, as I mentioned, is a comparison of surgical versus percutaneously created arteriovenous hemodialysis fistula. And Dr. Smeds will start us off with this article.
Great. Can you see my screen there or no?
It says professor.
Great. That's the correct screen, right? So, Dr. Stoner was talking about how carotid surgery got a lot of us into vascular surgery, and I would argue that hemodialysis is just as sexy. So we're going to be talking about percutaneous fistulas and a paper that was recently published that's comparing these to surgical fistulas. I don't really have any disclosures relevant to this talk, other than the fact that I do these procedures. I do both wavelength and ellipsis here. I've also received a couple of slides from both Bard and Medtronic that have some nice pictures. So the goals of dialysis access is to create a usable or functional access for these patients that will have minimal complications for the placement, as well as long-term patency. You also want them to have optimal patient experiences with minimized subsequent procedures. Up to this point, arteriovenous fistulas were created surgically only, and these were the preferred access for dialysis. There was a limited number of surgical creation sites, most commonly the brachiobasilic or the brachiocephalic, and most of these relied on a single vessel outflow, which sort of limited the options. These fistulas, as we all know, have variable maturation rates with pretty high failure rates, up to 53% over the relatively short-term period. Most of them require several months to mature. There's often flow-limiting lesions at the site of the surgery that are associated with this maturation failure. And most fistulas require up to 3.4 interventions per year on average to maintain a working fistula. Percutaneous fistulas kind of came onto the scene over the last couple of years. And there's two main players right now. There's wavelength, which uses radio frequency electrodes between orienting magnets to create a connection between the ulnar artery and the ulnar vein, or the radial artery and the radial vein. And then there's the ellipsis, which uses thermal energy to create a connection between the radial artery and a perforator vein. This uses no angiography, no contrast, is completely ultrasound driven. So the benefits of both of these ways to create percutaneous fistulas is to avoid surgical scarring, to minimize vessel trauma, to make consistent sized connections, and to benefit from the dual outflow that you often achieve in these patients. These fistulas will have lower flow rates and therefore a lower shear stress, which hopefully will diminish the amount of complication caused by intimal hyperplasia and other issues with outflow. There's a fair amount of current literature on both the wavelength and the ellipsis, and both of these have very appealing data points. Now, this is highly selected patients for FDA approval, but these have high cannulation success rates, low times to cannulation, and a significant number of patients who are without reintervention in the short-term period. Both the wavelength and the ellipsis have multiple articles looking at this. However, there's very few articles looking at a direct comparison with surgical fistulas, and the authors of our presenting paper hope to get over this by presenting some of their data. So with that, I'm going to turn it over to Charles. He's our current second-year integrated vascular resident here at St. Louis University, and he'll be talking about the paper, Comparison of Surgical versus Percutaneously Created Arteriovenous Hemodialysis Fistulas. And I'll go ahead and stop sharing and let him share.
Right. And is everyone seeing that screen? Yes, great.
Yes.
So,
yes.
as Dr. Smeds said, we're talking about the paper comparison of surgical versus percutaneously created arteriovenous dialysis fistulas by Harika et al. So some of the introduction is what Dr. Smeds mentioned. With surgical arteriovenous fistulas, you can have those primary failure rates between the 23 and 60% range. And then you can also have complications like hemodialysis access, induced distal ischemia at 28% in some of the brachiocephalic and brachiobasilic fistulas. And then with your brachiobasilics, they noted a dehiscence and infection rate of 13%, which is pretty high when you're talking about the number of patients that are receiving these dialysis accesses. So the question is, what can these ellipsis and percutaneous AV fistula creation modes do to improve these kind of numbers. And the way that this is performed is, as Dr. Smed said, the proximal radial artery to a perforating vein at the elbow under ultrasound guidance. So they looked retrospectively between May 2017 and 2018 at outpatients receiving percutaneous fistulas versus surgical fistulas. The outcomes, they looked at maturation, complications, and additional procedures required. The primary outcomes were maturation with the definition of usage of the fistula or clinical examination and ultrasound criteria, with the criteria being 4 millimeters or 500 cc's per minute of flow. The other primary outcomes were the primary and secondary patency from index to intervention and then index to abandonment. Some secondary outcomes that were looked at were the number and type of interventions, either percutaneous or surgical, and then the complications, wound healing, infection, and Steele syndrome. The groups were broken down primarily by percutaneous versus surgical, but the surgical arm included both those fistulas done at the wrist and at the elbow. And so they did break down percutaneous versus wrist and percutaneous versus elbow fistulas as well. And then the stats, t-test, chi-squared, Kaplan-Meier. So the characteristics between the surgical and percutaneous fistulas were generally similar, apart from the hemodialysis, patients that were currently on hemodialysis when they received their access. The percutaneous were more likely to be currently receiving hemodialysis. And then, as I mentioned before, there's the methodology, the way that the percutaneous is created, those were all at the elbow. So between there, the second blue box is just showing that surgical fistulas were made at the wrist, whereas percutaneous weren't. In the subgroups broken down into the wrist, there was a similar discrepancy between the characteristics at the wrist and the percutaneous, being the hemodialysis patients, and then at the elbow versus percutaneous, there were no differences in the characteristics. Looking at the outcomes, the blue boxes just highlight where one method is superior to the other. So in the surgical versus percutaneous, the two large groups that were looked at, maturation at 6 weeks was higher in the percutaneous group. At 12 months, primary patency was higher in the surgical group. Secondary patency was the same. Wound infection was lower in the percutaneous group. And then interventions at 12 months were higher in the percutaneous group, particularly with percutaneous interventions, with 41 being required in the percutaneous group and only 4 in the surgical group. But then surgical interventions were much higher in the surgical group. And then looking at 24 months, there were not many significant differences between the two. However, at the 24-month mark, surgical interventions were less common in the percutaneous group. Looking at patency rates on the Kaplan-Meier graphs, there was a statistically significant difference in the primary patency, with it benefiting the surgical group over the percutaneous group. But with secondary patency, there was no significant difference there. For the subgroup of elbow versus percutaneous, wound infections rates were lower with the percutaneous group. Intervention, number, percentage, procedures were percutaneously they were lower at the elbow, and surgically they were lower with the percutaneous group. And then at 24 months, the interventions were the only difference there, with the percutaneous group requiring fewer surgical interventions. And again, the primary patency was statistically significant with the surgical elbow group having higher primary patency, but then there was no statistical significant difference in the secondary patency between the two groups. Looking at the wrist as well, there's a general trend with wound infection again, lower in the percutaneous. Intervention numbers, percutaneous intervention was required less in the surgical group and more in the percutaneous group, but surgical intervention was higher in the surgical group. At 24 months, there were no statistically significant differences between the two groups. Looking at primary patency, similar to the other two subgroups that were compared, The primary patency was higher at the surgical wrist, and there was no statistically significant difference at the secondary patency over the 2 years. Some of the discussions that were had in the article, they talked about how the primary patency, there was a much higher primary patency in the surgical group, but the percutaneous access and the percutaneous AV fistula that was created is quite small, around 4 millimeters. And a lot of those did require an angioplasty. But once that had occurred, they then matured well and didn't require much secondary intervention. And that's where you see the evening out of the numbers. And then the secondary patency at around 300 days basically equalized between the percutaneous and surgical group, with the percutaneous being not significantly, statistically significantly better, but slightly better by the numbers. And then with the secondary outcomes, wound infections and surgical reintervention were much lower in the percutaneous group, as would be imagined. And then another advantage of the percutaneous is that it can be formed by more physicians, vascular surgeons, interventionalists, both in nephrology and cardiology, or interventional nephrologists, depending on who gets trained. Some things I was hoping to discuss with the authors. There was a conflict of interest with 2 of the lead authors being consultants and shareholders. It was a retrospective paper, so it has all of the intrinsic limitations of that, which we will deal with. And then there is some selection bias with which patients are chosen to undergo the percutaneous versus the surgical, and also with wrist versus elbow, and then breaking that down between brachiobasilic, et cetera, requiring superficialization. There was also no data available for the vessel size of each group. They did note in the methodology that vessels under 2 millimeters were not used, but it would have been interesting to talk to the authors about what sizes they may have seen, or if they saw any discrepancy between the 2 groups. And then similarly to a lot of these new devices, the sample size for the elbow comparison was 47 for the surgical, and that being the location where the percutaneous was made. I was wondering if the authors thought there were some limitations in that sample size to make a direct comparison there. So that is everything I have on that paper.
Well, Charles, very nice discussion. This is David Dawson. I'm dialing in from Temple, Texas. I'm supposed to address the authors first, but I just thought I'd ask you your impression. What do you think? Good idea, bad idea, somewhere in the middle? You're muted.
There's a clear advantage from the aspect of wound infection, which is something which is a big deal, and the superficializations and the secondary surgical interventions that people have to do in the 2-stage brachiobasilic or in the brachiocephalic if it's not superficialized enough. But it seems I need to read more about the specific device and what limitations there are on the patient selection, because I think that would be a huge limitation that I would probably encounter pretty quickly. Which is also a limitation for the surgical. We need the right vessels in the right places, but this is just in the proximal radial, just with that crossing vein, whereas with surgical, you do have more choices available.
Well, so I think you've just hit on a really important point, and that's always patient selection. We're always trying to select the right procedure for the right patient. Dr. Malios, can you address that? It says in the paper that 60% of patients who are considered for percutaneous fistula creation were appropriate candidates. What were the exclusion criteria first, and then a follow-up question?
Yeah, so first of all, thank you for having me, and thank you for this excellent presentation and the questions. The exclusion criteria were mainly patients, of course, the patients that had the distal fistula, had the distal fistula. And then what we're looking after the distal fistula is to create a proximal radial artery fistula. And whenever the puncture is possible, ellipsis is now our standard of care. So I wouldn't specifically say exclusion criteria rather than not being able to do the puncture. I also had a couple of questions by Paul in the chat. One is the learning curve. And the learning curve, I would probably say that you will need 5 to 10 cases of proctored cases, and you will probably need 20, after 5 or 10 cases, you can do it alone. And after 20 to 30 cases, you're getting pretty good at it.
Okay. We had some other questions in the chat. One is what do you tell patients about the need for secondary intervention after, especially percutaneous creation of a fistula?
Well, first of all, what I say to patients that get a fistula, not only percutaneous fistula, is that this is going to be a long-term relationship, and it is like when they're buying a car and they have to often come back for a checkup or several different kind of procedures. So if they think they're going to get one surgery and then forget about me, that's probably not going to be the case. Either they get surgery or percutaneous fistula. Now, especially for the percutaneous fistula, and to justify, if you wish, the higher risk for dilatation in the first period, not overall, essentially what we're saying is that because this fistula is creating a less wide opening between the artery and the veins, sometimes we may need to come back and tailor it and balloon it and give it a bit more force. However, on the other hand, and I'm very positive about this, I think these patients have peace of mind in the longer term, because essentially we're creating a hemodynamic profile more similar to the distal fistula, because you have radial artery inflow and multiple venous outflow. And this is why these fistula, after they're getting stable, they're behaving the same way this distal fistula we have in some patients are in the long run, because they have low pressure and lower flows.
Thank you. I do want to especially thank you for joining us, noting that the time in Paris is 1:49 a.m. Clearly, you're a dedicated educator. Leanne Chavez in the chat, Leanne from New Mexico, has noted that for the secondary interventions, she wanted if you stratify between the types of types of percutaneous interventions or AV fistula that needed these interventions.
Well, I would probably say 99% of these interventions were dilatation of the anastomotic and post-anastomotic segment. You have two types of procedures, essentially. One is that you will get your fistula with low flow, and then you can go from the radial artery and just get the wire through easily and balloon it, and we'll usually use a 6mm balloon. And sometimes you might have no flow through the anastomosis, but what is good with the percutaneous fistula, because there's no ligation of the branches, is that you only have a plug at the anastomotic chamber, and you can do a sharp needle canalization, and the fistula goes back again, which is not the same as with surgical fistula that you have to do a thrombectomy or thromboaspiration.
Dr. Jennings, my neighbor to the north. A couple of questions about study design. In the paper and in Dr. Smed's introduction, it was characterized as a direct comparison. But these are retrospective analyses of patients who weren't selected for the procedure using similar criteria. They weren't randomized. And importantly, the outcomes with fistulas created at the wrist are often different than fistulas created at the elbow. The elbow level fistulae are more likely to cause hand ischemia. Wrist fistulas are more likely to have failure for maturation. Why weren't there two different control arms of equal size, a wrist-based fistula and a elbow-based fistula compared to the percutaneous fistula?
Thank you for the question. I think that part of the interest in this article was that it represents the first 107 cases that Dr. Malios completed with the ellipsis device, and he and his group have done, what, 4,000 or 5,000 other surgical fistulas. So we're comparing that type of experience between the two arms. When he says elbow fistulas, from our experience together, that almost always means a proximal radial and occasionally a proximal ulnar inflow fistula. And I would emphasize that that's a different animal than what we see as upper arm fistulas in most American practices, where it's based on brachial artery. And slowly, I think there's some awareness of the difference between those two cases. You're going to have a higher flow, higher turbulence. You'll have more aneurysms, more Steele syndromes, more swollen arms, more cephalic arch problems, just a list of things. So in Dr. Malios and my practice and those in his group, we try to use proximal radial artery, which is obviously what the ellipsis device uses. He authored a paper that I helped him with comparing the analysis of flow characteristics of proximal radial artery or ellipsis fistulas and wrist fistulas. And they were essentially, the flow characteristics were essentially the same. Alex may want to comment on that. But I think the radial artery, whether it's distal or proximal, offers a much safer, much more successful fistula. I don't know, did that answer your question?
Well, I think it addresses it in part. It's just that the control group was fairly heterogeneous. For example, if we look at maturation, the elbow-based fistulas, surgical fistulas, had the same maturation rates as the percutaneous. And so if we're looking at advantages in maturation, maybe we're really talking about differences between the elbow and the wrist.
Right. There are other advantages. Of course, clearly we're comparing an expert surgical creation of a surgical fistula with an expert ellipsis creation, even though it was his first 100 cases. Another advantage that may or may not have been commented, I can't recall, is I think Dr. Malios, I've seen him do many of these, and I think he averages 10 to 15, 20 minutes at the most to do a case. And I mean, they're in the room and they're out of the room, and they have a 600 flow fistula that in 2 weeks is a 900 flow fistula. So I don't think that can be discounted either. It takes fewer resources. Obviously, you can tell I'm a fan of this procedure, but it is impressive to visit Dr. Malios, and I'm sure he would welcome everyone here to join him in Paris for a pleasant week's visit.
So there was a question that related to those ultrasound findings after fistula creation, and a question might be posed slightly differently. The criteria for maturation were either successful use for dialysis or reaching a threshold size of, was it 4 millimeters and a flow of 500 milliliters per minute. But most of us in the US are taught that you need a 6 millimeter fistula with 600 mil per minute flow. Are we looking at maybe skewed definitions of what is success with maturation if we use an easier threshold, or is that a functionally appropriate threshold? Are 4 millimeter fistulas being successfully cannulated, and can you get good dialysis on a 500 milliliter per minute flow?
So the criteria we used was the same that was used for the pivotal trial of ellipsis, and it is actually consistent also with the European Society guidelines, because some people argue that the 6 millimeter diameter, it's perhaps a bit excessive. Actually, the paper that was quoted, I think, is basically mentioning that if you have 4 millimeter diameter and more than 500 milliliter flow, this fistula is more likely to be used. So again, you know, the criteria for maturation, although the 666 is widely used, there can be some discussion about it. Having said that, I do agree with you that given the retrospective nature of the paper and the fact that we were looking very closely in this percutaneous group and not necessarily the same way the surgical group, there may be a bias there about the maturation for sure.
Maybe you can help.
I might add to that, you can look at Jeff Hull's recent paper. He, after the trial, the initial trial, he then kept a registry of all his cases, and he vigorously tried to have higher flow and higher diameters, leading to more interventions, but prompt early cannulation and high degree of success. So I think you have to tailor your actions to the needs of your dialysis units.
A couple of questions had to do with using the fistulae when they're created. In France, are the dialysis centers doing ultrasound-guided, point-of-care ultrasound-guided access to the fistula that might help with a 4 millimeter rather than the folks in the US who need to feel a really big 8 millimeter fistula to be successful?
I wish they would do ultrasound-guided cannulation. Actually, I think the best ones about ultrasound-guided cannulation are in the Netherlands. I think they're very advanced in the Netherlands. However, in France, this remains a problem. It has been a struggle for me to be able to work with my dialysis units and, go around with my ultrasound and try to train people. And it is becoming more difficult now that we have more patients, to deal with this. And sometimes, I have to admit it might even be discouraging because, when people are familiar having 1 liter fistulas going through one vein and, they like high pressures, aneurysmal fistulas, easier to stick them. It's difficult to convince them that, in the long run, it's not good for the patients, I'm hoping that at some point, I see light in the end of the tunnel, and I see nephrologists that are becoming more sensitive about getting trained and using ultrasound and guide nurses how to stick fistulas appropriately. And that's not only a percutaneous fistula, so it's for all fistula.
Well, hopefully the lower price of some of the point of care units will be a driving force to prompt adoption. I think this
Could I make one more comment, Dr. Malios? I think very few of your fistulas, I don't remember any of the ones we've done have become 4 millimeters. So certainly that was a data point. And one of the problems with the database was that you didn't have the absolute diameter of each fistula to express when they started cannulation. So I think I would not overemphasize the 4 millimeter minimum requirement to write the paper. The ones I see are just like any other proximal radial artery fistula at totally adequate diameter.
Well, great discussion. It puts much of the paper in better perspective, and it also helps us understand what are some of the unanswered questions about how to compare different techniques, and maybe help us a little bit better understand who gets what. Paul, thank you very much for inviting us. Misty, thank you.
Fantastic job, everyone. I'm super grateful.
Absolutely. We're very grateful to the University of Rochester for being one of the sponsors along with St. Louis University. We had excellent discussions generated by Dr. Jorgensen and Dr. Dawson. And having the authors here is really one of the most important parts of it. It allows us to really pick apart some of the work and try to think about how we're going to do it better next time. So thank you all for joining us. I will reach out to Dr. Malius about a job in France. Don't worry. I'm sure several of us will. But we can't wait to have everybody back in August. So the next event will be August 10th, as I mentioned, at 8 p.m. Eastern. You will see advertisements on social media, on SBS Connect, on the APDVS Connect, and we do send out emails to each program director. So thank you all for joining us, and have a wonderful night.
Thank you.
Thank you, guys.
Thank you.
That's fantastic.
Yeah, that's great
work that they do too.
Get some sleep, Alex.
It's a lot of work. It was wonderful.